Hello, let's talk about valvular heart disease. You have four valves in your heart, and they are constantly opening and closing in a rhythmic cadence around the cardiac cycle. Now, an inability of these valves to open or close properly results in flow disturbances. And this can lead to a volume overload or a pressure overload, depending on where the disturbance is. And your heart responds to volume and pressure overloads by hypertrophying or increasing the size of cardiac muscle, right? And so all of these valve pathologies, because they lead to flow disturbances, lead to hypertrophies in characteristic areas of the heart that kind of match up with the deficient valve. So that's where we're going with all this. And there are various pathologies at the cellular level that lead to valve damage, but mechanically, we're referring to two real classes of valve damage. We're talking about stenosis and regurgitation. And you can narrow the concepts of this lecture down to that and then apply those concepts to any of the four valves that you have in your heart. A stenosis means that we've got a problem pushing blood through to the other side of the heart. And then a regurgitation means that we've got a hole in a valve that means that we're pushing blood backwards through the heart when we shouldn't be. And so those two concepts, again, you can apply it to any of the four valves in the heart, and they're particularly important because we can hear the flow disturbances created by valvular stenoses and regurgitations. And such audible sounds are very useful diagnostic tools for us because they allow us to very quickly inference what's going on with this patient's heart without having to stick them in a scanner. So we're going to start off with aortic stenosis, which is the most common valvular damage. And then we're also going to talk about mitral valve prolapse, which is another very common form of valvular damage. And the others, I would say, are pretty low yield in comparison to those big two categories, but they're also worthy of knowing about just in case you ever encounter them. And then at the very end of this video, we will review the heart sounds and the physical diagnosis associated with each specific valve deficiency. And if that's what you're here for, feel free to go ahead and skip to that part. So a very big concept is that whenever you hear a murmur that's associated with a valve, the sound of the murmur is blood hitting the valve. And as a result of contact with the valve, turbulent flow is created. And so it's the turbulence, yes, but what makes that turbulence, what generates that turbulence is an imperfection in the valve in the form of a stenosis or regurgitation. So the sound of the murmur is the blood hitting the valve. That's step one. And anytime you hear a murmur question, you can trace it back to what valve is being disturbed by applying this principle. Again, where am I hearing it? What valve does that correspond to? Because you know that what you're hearing is the sound of blood hitting the valve. So as an introduction, we've got stenosis and insufficiency, as we've said. And a stenosis is when a valve doesn't open all the way. And this is very bad for forward flow because it means that we can't push all of the blood through a valve that we ought to be pushing through it. And then an insufficiency, which is also called a regurgitation, means that there is a hole in the valve. And so that means it can't close properly. And so that means that there's some backward flow that's allowed through that valve. And again, depending on where it is in the heart, this can lead to a pressure or a volume overload. And the two examples given in the text are aortic stenosis leading to a pressure overload and aortic regurgitation leading to a volume overload. And a pressure overload is essentially the same as a high afterload because remember that an afterload is kind of the weight of the blood that we're pushing against if we're the heart. You know, it's kind of like the barbell we got to get up off our chest. And then a preload is going to be basically volume. More volume, more preload. And again, we know that with more preload, the heart snaps back into place with a greater force. That's the Frank Starling law. And so those two things, afterload and preload, are going to manifest as different changes on a pressure volume loop and ultimately different changes at the biological level, because how the heart hypertrophies in response to a high afterload is not the same as how the heart hypertrophies in response to a high preload. And we're speaking in a pure categorized sense here. And it's important to note before we get into this that both of these things can happen at the same time, and they can happen in various proportions. You know, they're not mutually exclusive. But at their cores, a pressure overload leading to a high afterload means that you're going to raise the top of a PV loop. You're going to pull it up, right? And you're also going to make it skinnier. It's going to have a decreased stroke volume. And so at the level of the cardiac myocytes, the myocardium, what that means is that you're going to see a concentric hypertrophy in an effort to squeeze high pressure blood out of the heart. And it's called a concentric hypertrophy because the prefix con means with or together. And so you're thinking with the center, concentric. That means that the direction of muscle growth is going to be towards the center of the lumen of the heart. And you're going to differentiate this from eccentric, and it's going to stay nice and separated in your mind if you remember that E means away from or out of. And so then you can remember that the direction of muscle growth is going to be away from the center of the heart. And so this is going to be the thin heart that you kind of characteristically see in systolic heart failure, which is a whole different SDL. And these concepts are included in this lecture just to allow you to visualize the sorts of changes that are occurring as we encounter the different valvular pathologies. So then it goes on to list our four main types of valvular heart disease. And you should know the most commons delineated in this one section particularly. Aortic stenosis, we're typically thinking it's age-related, although it could be due to a bicuspid aortic valve. Aortic insufficiency, pretty rare, usually associated with infection or dissection, although it can be due to aortic stenosis due to hypertension of aging. A mitral stenosis, rheumatic heart disease, is the most common cause of that, which is not very common in America, but is more common abroad. And then finally, mitral insufficiency or mitral regurgitation, also known as mitral valve prolapse, is most commonly due to this underlying cellular pathology called myxomatous degeneration. And so of these four, I would say, know the most common causes of each heart disease, each valve disease, and pay attention throughout the text to why they're occurring. So aortic stenosis, that's not this section. This section's, well, yeah, it is aortic stenosis. So what this section is saying is that normally your aorta gets thicker as you age. And in some people who have a bicuspid aortic valve, this process speeds up. And so it'll happen at an early age. And rheumatic fever can also cause an aortic stenosis. But as we're going to see, that's a separate gross presentation. So aortic stenosis is pretty common. It's the most common valve disease, period. And the most common cause of aortic stenosis is going to be this calcification of aging, and it's very multifactorial. It's this degenerative calcific stenosis in which you've got a normal tricuspid aortic valve, and then there's no commissural fusion. So what that means is the commissures are basically going to be the sides of the leaflets. And if you have a rheumatic valve disease, then due to the deposition of collagen, as a result of inflammation, the leaflets of the valve can fuse together, right? And so your two leaflets will start to beat as one leaflet. And so that's characteristic of rheumatic valve disease, and that's not seen in typical valve stenosis of aging. And then again, calcific aortic stenosis. This is the same pathology as the one above we'll see, except it's just more of a rapid onset because people with a congenitally bicuspid aortic valve have a distribution of flow across the leaflets of that valve that puts more pressure and stress on the valve itself, on the tissue of the valve over time. And so the same thing is occurring. It's like age-related, damage-related calcification. It's just engendered to occur earlier due to the bicuspid nature of the valve. Until recently, the concept was viewed as a purely age-related and degenerative disease, but what we're now starting to discover is that it's very multifactorial. There are several things that play into it, and we've even observed LDL inserted within the tissue of calcified valves. We've also observed angiotensin converting enzyme within the tissue of calcified valves, and we know that angiotensin 2 is a sympathetic activator and can lead to apoptosis locally. And so the presence of these two things within a valve let us know that factors that increase LDL or increase angiotensin converting enzyme are also going to increase calcification of a valve. And so that's all that the top of page 6 is telling you here, is that it's very multifactorial. But what it narrows down to is that the valvular interstitial cells are going to sort of differentiate into an osteoblastic phenotype. And remember that osteoblasts build bone. And so that's how the calcium gets in the valves, is that the interstitial cells in between endothelial layers of a valve, right? You've got a valve with two endothelial layers on either side, and then you've basically got fibroblasts in between. And these fibroblasts can get phenotypically switched into an osteoblastic mode, in which they start throwing calcium everywhere into the extracellular matrix. And that's where the calcium comes from. And looking at some gross images of a calcified aortic valve. Right here, you can really see it's got a lumpy appearance. Looks like a geodude, you know. It's rocks. It literally is rocks. I mean, it's a calcification, and typically the valve flap is going to be really thin like that. It's going to have a thin margin, and you're going to easily be able to see the bumpy outgrowths on those thin valve flaps. And if you take a histological section of any one of these tissues, what you're going to see is a bunch of big rocks inside the structure of the valve, where you should have normal cells. You know, this should be histopathologically normal. And if you look in the bottom right, like this section of the valve over here, that's normally what a valve looks like. But then you can tell that there's just this big rock here, and it's ruby red, and that's inflammation on H&E. And so that's a calcific nodule cross-sectioned out of a valve. And then again here, this is it's a normal tricuspid valve with some calcifications on it. We go back up, we see this is a bicuspid aortic valve, right? And so obviously we know that this is going to be the sort of anatomical anomaly that's going to lead to an early presentation of a calcific stenosis. And again, in both of these, the reason why the calcium is because all the fibroblasts inside a valve transform into an osteoblastic phenotype. And remember, phenotype's not the same as a genotype. A phenotype means what it looks like on the outside, and a genotype means what something is on the inside. And so the phenotype means they're not literally osteoblasts, but they're performing an osteoblast-like activity. And so then we get into a rheumatic aortic stenosis. And we notice that the valves in a rheumatic fever-related, rheumatic heart disease-related aortic stenosis are pretty fibrous, but other than that, they maintain their general topography. They're not overly rocky. They're not lumpy or bumpy, really. They just have some sort of crud on the top of them. And the fibrous tissue created by your immune system, because again, rheumatic heart disease is of immunologic origin, can cause the commissures, or kind of the sides of your valve leaflets, to fuse together and stick together. And so that's what you're seeing here in this picture, is that valve 1 right here and valve 2 right here are fused in the middle by the presence of such fibrous tissue over top of them. So that's your rheumatic stenosis grossly, versus just your calcific stenosis, in which the valves are not going to be locked up together. Now, going back into the text, we're talking about congenitally bicuspid aortic valves, and they're fairly common, 1 to 2% of the population. And the calcium in a bicuspid valve tends to deposit on the raphe, which is the raphe. It's this kind of a hump on the larger of the two bicuspid aortic valves, and calcium likes to sit right there in the middle of that raphe. And then getting on down to the top of page 7 here, it's saying that if you have calcification of the aortic valve of a rheumatic origin, it's typically going to present with fibrous histology and fusion of the valve commissures. And then you're also going to see some neovascularization too there. So moving into the clinical presentation of an aortic stenosis, thinking about what an aortic stenosis is, we know that a stenosis is an impediment of forward flow. So an aortic stenosis means that we can't pump blood out of the left ventricle and into the aorta. So what that immediately leads to is a pressure overload of the left ventricle, because it's having to generate higher and higher pressures in order to overcome the stenosis and maintain stroke volume. Because remember, up here, we said that when you increase afterload, your stroke volume goes down, right? But you need to keep stroke volume because you need to keep all your tissues perfused. And so that's why your heart hypertrophies as it does, is to maintain a proper stroke volume. So thinking about that, the heart's going to hypertrophy, and then eventually it's not going to be able to keep it up, right? Because the afterload doesn't go away, it just gets worse. And so as the afterload gets worse, stroke volume diminishes. And whenever stroke volume diminishes, cardiac output goes down. And whenever cardiac output goes down, well then, as we said, your brain's not getting enough blood, your organs aren't getting enough blood. So that's why aortic stenosis presents with dizziness and even fainting during exercise. And that's a very characteristic symptom of, amongst the 4 valve diseases, aortic stenosis is the one that presents with fainting during exercise and chest pain. And the reason for both of those is, again, a decreased cardiac output, meaning that it's a decreased oxygen supply to end organs, including the heart. That's why you get the chest pain that presents kind of like a coronary syndrome. And whenever the left ventricle hypertrophies enough, it can create a volume backflow into the lungs, and volume backflow into the lungs is going to mean a high hydrostatic pressure in the blood vessels of your lungs, and that causes fluid to leak out into your lungs, and this causes a pulmonary edema, which is associated with coughing and dyspnea on exertion. And it's a result of the volume overload in the lungs, secondary to the volume overload, the pressure overload really on the left ventricle. And you're going to hear a characteristic murmur, and we're going to get into that at the end of this SDL. The prognosis for an aortic stenosis is pretty good with treatment, but if it's untreated in old patients with several other comorbidities, most of the time, it's a 50-50 shot in the short to midterm. So now let's start talking about the mitral valve. The mitral valve is an atrioventricular valve, which means that it permits the flow of blood from an atrium into a ventricle, and specifically it's on the left side of the heart. And its proper closing is essential to prevent the backflow of blood from a left ventricle to a left atrium. And so if there's a problem in the integrity of a mitral valve, it can lead to a stenosis or a regurgitation. And so the mitral valve is surrounded by an annulus. And if you don't know what the valve annulus is, then you should Google it and look at a picture of it. It's essentially the skeleton of the heart, right? And so a calcification of the mitral annulus is going to be a calcification not of the valves themselves, but of the ring around the valves. And grossly, this looks like this. You can see that the zone of calcification is more so around the perimeter of this circular valve rather than it is along the cusps of the valves here, And so because you don't see calcifications on the free flaps or cusps of these valves, you're seeing them around the periphery again. You're thinking, okay, this could be an annular calcification. That's most likely. It's believed that annular calcification is linked to atherosclerosis. Again, lots of the same risk factors, going back to the theme of generalized inflammation in the blood. And the pathology that you see is pretty similar to the pathology of aortic valve calcification that we just looked at, wherein cells get switched to an osteoblastic phenotype and they start depositing calcium, and too much calcium in tissue messes up healthy cells. And so this can mess up your conduction pathway. This can agitate myocytes and cause them to proliferate. This can agitate fibroblasts and cause them to throw down some scar tissue. So all of that's going on with a mitral annular calcification. And we see it grossly here in the middle of a gross section. And we can also see it on x-ray. And the reason why we can see it on x-ray is because it's calcium. So it's bone, right? And it's going to present as this strip, this stripe on x-ray, right where the mitral valve would be. And here I've got an axial section of the same phenomenon. Notice how it is just lighting up and glowing. And that's, again, because it's bone. And the fact that you can pick up the annular calcification on an x-ray is stated 4 times in this SDL. So I would say expect the x-ray with this pathology on the exam. And when you see it, make the diagnosis like that, because it's a rather wide swath of calcification. And if it's just a couple of bumps on a valve, no, that's not the answer. It's got to be the annulus, because that's a lot bigger than the leaflet of a particular valve, right? So what sort of complications does this lead to? How does this present symptomatically? Well, it can present as a mitral regurgitation. And the reason for that is that your valves are just going to be the mitral valves will get heavier and heavier and heavier, right? And so your papillary muscles have to pull down your valves every time they want to open your valves. But if the valve is getting heavier, that means the papillary muscles got to do more work. And as the valve gets heavier, maybe the muscle isn't pulling it down enough, right? And so that can increase tension on the chordae tendineae, which are your heartstrings. And this can even cause the chordae tendineae to snap. And when that snap happens, well, your papillary muscle's sitting there working away, but it's not attached to the valve. So it's not pulling the valve down. And the valve has nothing else to do with its life but just prolapse. And so that's what it does. And so that's how you get a mitral regurgitation from the deposition of calcium within that tissue. However, a calcification of the annulus can also lead to a stenosis. And we know that a stenosis is an impediment of forward flow. So as that valve gets heavier and heavier, but before it ruptures, because it's heavier, whenever the papillary muscle tries to pull it down, it can't pull it down all the way. And so because it can't pull it down all the way, the opening of that valve, of the mitral valve, is going to be narrowed or diminished in size. And so this means less forward flow can fit across the mitral valve when it ought to be. And if you've got a diminished forward flow across the mitral valve, because that leaflet is heavier or more difficult to pull down, then that's called a stenosis. So that's why an annular calcification can result in either a regurgitation or a stenosis. It can go either way depending on the consequences involving that papillary muscle that's pulling that thing down. A annular calcification, remember the annulus is the ring around the mitral valve, can also lead to an arrhythmia if the calcification starts to damage nervous tissue pathways. Possibly calcification could cause scar tissue to get laid down kind of as an obstruction in a conduction pathway, right? And then finally, a calcification, if it causes a stenosis or a regurgitation, well, both of those are going to lead to volume overload on the left atrium. And if the left atrium hypertrophies, well, then it's going to stretch, right? And if it stretches, then what that means is that the conduction pathways of the nerves throughout the side of the left atria also get stretched. And then they get frayed like some broken wires. If you've ever had an iPhone charger, that kind of broke like at the tip, right where you plug it into the phone, and it started getting frayed because you just used it too much, like that's kind of the same visual as an arrhythmia that gets generated via an atrial hypertrophy. And then finally, a consequence of atrial hypertrophy, again, non-specific to prolapse, regurgitation, or stenosis, we're speaking purely about left atrial hypertrophy here, is stroke and endocarditis. And both of those are going to be due to stasis of blood. And let's walk this back to the beginning, right? You got a problem with your mitral valve, which means that either not all the blood is emptying out of your left atrium or some blood spilling back into your left atrium, right? So regardless of if it's a stenosis or a regurgitation, you got too much blood in your left atrium, okay? So that's a volume overload. And when you have too much blood volume in a confined space, well, it can't go anywhere. It's not mechanically favorable for this blood to move around and interact with itself. So it slows down. And because the flow slows down, well, we call that stasis. And we know that stasis is one component of Virchow's triad. And that means three things that make clotting more likely. And they're wall injury, stasis, and coagulability. So if you have a slowing down of blood flow within a chamber, it's basically pooling and coming to settle. That can certainly encourage a clot. And if it can encourage a clot, well, it can also facilitate the attachment of different pathogens, specifically bacteria, but also viruses, to the endocardium of the heart. And this is occurring in the left atria, specifically because the left atria has this thing on it called the auricle, right? And if we're looking at the left atria here from the inside, we see that the auricle is going to be this sort of cavern in the wall of the atria. And then the mitral valve is going to be down here, right? So whenever you pump blood out of the atria, you're not pumping it into the auricle, you're pumping it out the mitral valve. But what the atrial appendage or the auricle is essentially a windsock on the outside of your heart. It's a pouch in which blood can invest and sit. And so anything that promotes stasis within your left atrium promotes the formation of a clot within your left auricle, which you may see as the left atrial appendage. And up here in the upper right, this is what it looks like on the outside of the heart. So when you're looking at it, it's not just a fat pad, it's literally a hollowed out opening. And again, here it is, hollowed out opening. So you can see that blood comes in through the veins and it should be going out the mitral valve. But if there's too much blood inside the left atrium, some of that blood gets rerouted in either direction into the left auricle. And whenever it just sits in this left auricle, what do we have? Stasis. The stasis encourages clotting. And so when you couple this with atrial fibrillation, you can see how a clot could just break out of this left auricle and go into the left ventricle and then into the system, right? So it's very easy to imagine not only how does a clot form in this space? Well, I mean, it's a dead end. It's a cul-de-sac. Blood's not moving there. There's your clot, you know, a bunch of fibrin just says, oh, hey, platelets. So how does that clot get dislodged? Well, a sudden rapid motion of the heart, as is characteristic of atrial fibrillation. You turn atrial fibrillation on, it's like you're sitting in a massage chair at the mall, right? That's a really bad thing if you have a clot up inside your left auricle. So that clot dislodges and moves into your brain or your kidneys or wherever else it wants to go. So that's I've said all that to say that anytime the left atrium hypertrophies, you're at a higher risk for clots. And it's specifically going to be with left atrial hypertrophies, which is going to be your two mitral valve pathologies. Again, they mention x-ray 4 times in here. If you get a question like this, it's got to have an x-ray in it because you can't make the physical diagnosis otherwise, really. Now let's get specifically into mitral valve prolapse. And a prolapse is a parachuting out of anything into anywhere it's not supposed to be. And I like the verb parachute because that's essentially what it looks like, is just a opened parachute of tissue, whether, you know, it's a rectal prolapse or an esophageal prolapse or a mitral valve prolapse. That's what it looks like. And mitral valve prolapse is characterized by this histopathological finding, meaning you're going to see it only on a microscope. It's called myxomatous degeneration. And so I really want you to be able to recognize this phrase, because even if you never get asked a question on myxomatous degeneration, I've realized it's popular as a confounding answer choice. And so you might get thrown a question where this is answer E, you know? And so you can narrow it down to C and E, you know? But if you don't know what myxomatous degeneration is, well, you might mess around and pick the wrong answer just because you're guessing based off something you've never seen before in your life. So understand what this is. And looking at some gross images of a mitral valve prolapse. This is parachuting right here. This on the right side of the screen, I mean, look at that shape. That's an army paratrooper basically. And then here you see it top down axial view. It's puffy, it's bubbly, it looks like a pastry, you know. And then you even slice it histologically and you realize, wow, it's got a lump to it. So that's what a mitral valve prolapse is going to look like grossly. And myxomatous degeneration is going to refer to the abundance of GAGs, or glycosaminoglycans, also known as mucopolysaccharides, within the tissue of this valve. And if you zoom in, you see that it's really loose and not very well held together. And that's because glycosaminoglycans are tiny little springs, or they're pillows. They're mechanically there in order to buffer shock, right? If they were a tool in a toolbox of your body, you know, of your DNA, they would be a spring. They are shock absorbers because it's just a long line of protein with some more proteins popping off of it with little sugars on it, right? And the sugars sequester charges. And so because they can sequester charges, they can compress and then reform back into shape depending on where the charges around it are flowing. So that's your myxomatous degeneration on a microscopic level. Here's another look at myxomatous degeneration under the microscope. Again, it's a lot of glycosaminoglycans, and that's going to be this middle section of the valve here. You can tell that it's washed out, particularly in this area. And the reason why it's washed out is because we know that sugars are prone to wash out whenever you prepare a histology slide for final staining. So I'm going to put in brackets here what a normal valve looks like, basically. Again, notice how flat this region is within the brackets. Notice how it doesn't have this kind of middle layer that's fluffing it up on either side of it. That's what myxomatous degeneration looks like under a microscope. And then one more time with the gross view. Here on the left, this is a normal mitral valve. And you notice how almost translucently thin it is whenever you take some sections of it here, right? But over on the right side, man, this thing is blocky, and this thing looks like it looks like a chunk of adipose, or it looks like soap, you know? I mean, it's really noticeably thicker and heavier and more dense than the normal valve on the left side here. So this here on the right, that's what your prolapsed valve looks like. And it looks like that because it's got a bunch of these glycosaminoglycans on the inside, on the interior, on the core of its structure. So going back to the SDL, mitral valve prolapse is the most common valvular heart disease in North America. And it's identified in 7% of autopsies. That's a lot. Generally, it can be so genetically rooted to where it's present at birth and it just progresses with age, or I believe it can kind of be acquired too, with, as we see, hyperthyroidism can be a cause of mitral valve prolapse or a cause of myxomatous degeneration. So what we see is that usually it's an isolated finding, and it's usually subclinical, meaning that the growth of this mitral valve, bigger and bigger, it takes a lot of growth, and it takes a lot of extra size on that valve for it to become clinically significant. There are a lot of different ways you can get this myxomatous degeneration. Don't worry about knowing them because there's so many different ways. It's kind of fruitless to ask a test question about it. What you need to know is the symptoms it'll create. Again, bottom of page 10, this is telling you how to recognize it grossly and under a histology slide. And then top of page 11, interesting fact, Marfan syndrome, 90% of people with Marfan's go on to develop mitral valve prolapse. It's due to this inability to metabolize glycosaminoglycans. It's due to an abundance of extracellular matrix. We know this is a collagen, this is a fibrillin defect, right? Fib1. So too much extracellular matrix, okay, valve problems. So finally, how does this present? With a classical auditory finding of a mid to late systolic click. And so a prolapse is a regurgitation. And so a mid-systolic sound makes sense, because if there's a regurgitation, there's a hole in the valve, which means that whenever your ventricle pumps, most of it's going out the aorta, but then some of it's going back into the left atrium as a result of the hole in your mitral valve. And so that's where the click comes from. It's the valve getting pushed open, and it's the turbulence of blood smacking against that prolapsed valve. And so you can hear a characteristic murmur. We'll get into the murmur at the end of this SDL. And then again, because the left atrium is going to hypertrophy with a prolapse, because the left atrium is going to volume overload, we recognize that clots are common, and then they can embolize because of the stasis in the blood, and they can occlude different places downstream. And then finally, arrhythmias again, going back to not prolapse or regurgitation. No, that's not why the arrhythmia is there. The arrhythmia is going to be there because of stretching out of the atrium, or because of the deposition of inappropriate material at the cellular level, as we saw with calcium in the calcified annulus, or excess glycosaminoglycans in this case. So now we got a brief blurb on papillary muscle dysfunction, and just what you need to know is that the papillary muscle pulls the valve down anytime it needs to open, right? And so regurgitations are very intrinsically linked to the function of the papillary muscle, and papillary muscle dysfunction can be induced by a non-STEMI or by a STEMI, basically by an acute MI. So if it's a non-STEMI, then your papillary muscle is going to be stunned and it'll temporarily be unable to function. But then once the reperfusion is complete, it'll go back to being able to crank again. But then if it's a STEMI, meaning if it's a transmural infarct, well, the risk of that infarct spreading to the papillary muscle is a whole lot greater now. And so if it spreads and the papillary muscle ruptures, right, well, then that's really bad, because then that means it can't contract, because it means that the blood supply to that muscle is almost entirely cut off because it's hemorrhaging within itself. So that section, just know that it's closely tied to acute MIs, that one paragraph. Carcinoid heart disease. Now for something way different. This is a etiology of tricuspid regurgitation and pulmonary stenosis. So there's two different disease processes affecting two different valves here, and both are caused by the same underlying pathology. And in a nutshell, it's called carcinoid heart disease because it's closely related to cancer. You have to have a cancer first. That's step one in the pathogenesis of this disease. Step two is that the cancer is going to metastasize to your liver. And then from there, it's going to release serotonin and other vasoactive metabolites into the hepatic venules, and then they're going to go into the IVC, and they're going to go from the inferior vena cava into the right side of the heart. And then the gross excess of all these metabolites, specifically serotonin, is going to induce a reactive fibrosis within the tissues of the wall of the right atrium and right ventricle, and this can include the valve. And so a big point to note is that this doesn't affect the left side of your heart at all. Why is that? Well, it's because your lungs have a very good blood system with a whole lot of macrophages, and the cells of your lungs will be able to filter and pull out all of the metabolites produced by this tumor from your bloodstream. So by the time the blood gets back to the left side of your heart, all that serotonin is no longer in your blood. So it starts with a neuroendocrine tumor. So we know that it's going to stain with synaptophysin and neuron-specific enolase. And another neuroendocrine tumor that we've seen is the medulloblastoma. And we've also seen some peripheral neuroendocrine tumors. And these tumors specifically are going to start in enterochromaffin cells. And so entero, we're thinking enteric as in gut. And then chromaffin cells, chromaffin means chroma means color. So it's going to pick up a whole lot of color whenever you stain it. So these are cells in the gut that pick up a lot of color when you stain it, right? And that means that we know they're secreting something, because typically picking up a lot of color, there's got to be something there to pick up color. So these cells are making or producing something, and they wouldn't be producing something just to keep it for themselves. They're producing something to release it locally. So that's the initial tumor. And then one of these enterochromaffin cells that turns cancerous is going to just pop off and metastasize, and we know that that can't happen unless a basement membrane is breached, but that's what happens here. And because the portal vein drains into the liver from the gut, right, I'm guessing that that's how these cells get into the liver from the gut. And so once it gets to your liver, it just sets up shop right next to a couple of hepatocytes, and it's doing its thing, secreting serotonin. And we know that this serotonin gets back to the heart and causes it to reactively proliferate. So the symptoms of carcinoid syndrome, which means you got the carcinoid tumor, which means you got a lot of serotonin in your blood. All the symptoms fit having high blood serotonin. Diarrhea, check. Flushing, check. Asthmatic attacks, check. So it's going to be a right-sided disease, and it makes the valve look like cauliflower like this, but the big picture here is on the left, because you notice it's a real non-specific pattern of seeding of injury here, pattern of injury, I should say. And again, it's usually going to affect the tricuspid valve first thing first, because that's the first valve that it sees, but then it could also affect the pulmonic valve. So the tricuspid valve is involved in 80 to 90% of cases, and specifically it can start as a tricuspid stenosis, lead to a tricuspid regurgitation. Pulmonic valve involvement is typically not going to be as severe or chronic enough to mediate the change from a stenosis to a regurgitation. And then the regurgitation with the tricuspid valve is made more likely by the fact that it's got these papillary muscles, chorda tendineae going on it, working so hard. So the right side of your heart is going to be enlarged. And then because the right side of your heart hypertrophies, you're going to get a volume overload on the right side of your heart because it's swelling up and it's turning fibrotic. And so what that means is it can't contract as hard. And that's why the volume builds up in the right side of your heart. So when volume builds up on the right side of your heart, well, then where does volume build up? Upstream of that? And the answer is in your liver, first and foremost. And so that's the hepatomegaly. And if it gets past your liver and the swelling persists in your gut, that's called ascites, right? And then if it gets down into your periphery, that's called a pitting edema. And then it's also associated with a low cardiac output, because the weak right heart means you can't push blood into the lungs, means you can't push blood into the left ventricles, means less left ventricular stroke volume. So that's the physiology going on in this sort of lesion. And you can see a trichrome stain again. I'm not going to get into the histology of that because I think that this one's so diagnostically obvious, again, with the symptoms, that you're going to know it's only right heart involved one way or another. They got to tell you that. So now we get into a section titled Complications of Artificial Valves. And you can have a mechanical fake valve, or you can have a bioprosthetic, right? Grown from graft of a different animal, typically. And the main complications of these artificial valves, no matter their type, is going to be clotting. Because remember Virchow's triad: wall injury, coagulability, and stasis. Well, do you have wall injury anytime you're putting a valve in? Well, yeah, because you got to cut open the wall to sew the valve in. Of course, you got wall injury. So do you have hypercoagulability? I would say yeah, because you've got this wall injury leading to the release of all these intrinsic locally active clotting factors. And then stasis. Are you going to have stasis? Well, you got to stop Buddy's heart for an hour to put the valve in. So yeah, you got some stasis there. And then plus they're going to be in a hospital bed after that. So you've got all three of the components that you need to form a big fat clot inside the right auricle of a right atrium, right? Or the left auricle of a left atrium, depending on the valve that's being replaced. And so this is the reason why we get these patients on heparin stat, and then we work them into warfarin, and then we'll keep them on clopidogrel and aspirin for a very long time after that, because we don't want any clots forming on this valve or the chamber of the heart in which this valve is adjacent to. And then alongside with the clot, infective endocarditis goes right alongside with the stasis of the blood. And then, I mean, we're cutting the dude open, for Pete's sake, like risk of infection right there. And typically it's going to be staph epidermidis. It can be strep. It can be fungus if you're in a bad OR. Surgical deterioration. Obviously, these things don't last forever. But they last a lot longer than we last sometimes. And then finally, kind of high shear forces, weird sort of flow abnormalities, And then overgrowth of fibrous tissue over the valve itself. That's kind of the body rejecting the implant. All these things can happen, and know that they're due to the valves. So this is the good part. We are now getting into how you diagnose all these different murmurs associated with the stenosis and regurgitations of various valves. And before we really break it down, a couple things I want to get out of the way. This SDL is talking about left-sided heart murmurs. And if there's injury to a valve on the right side of the heart, it's going to present in a way that makes sense. If you think about the pressure volume loops associated with each of these and work backwards. But there's a big difference between the left side of the heart and the right side of the heart. And that's that left-sided heart murmurs are going to get louder whenever you breathe out. And right-sided heart murmurs are going to get louder when you breathe in. And the reason for that is that when you breathe in, you're increasing preload to the right side of the heart, but you're actually decreasing preload to the left side of the heart, because whenever you breathe in, you're expanding your lungs and thus decreasing the pressure within your lungs, right? And so when that happens, you make your lungs a more low pressure zone, and blood wants to stay in your lungs. It doesn't want to go back to your heart. And so that means blood's less likely to return to your left side of your heart. And then when you breathe out, you increase the pressure of your lungs. And then that blood's like, okay, I'll go into the left heart now. And so that's why the left-sided murmurs get louder on expiration versus the right-sided murmurs. So principle number one, the sound of the murmur is blood hitting the valve. So if they give you where the stethoscope is at, and then they give you the timeline of the murmur, you should know exactly what valve is compromised and what sort of compromisation it is. Bottom of page 13, top of page 14 is really talking about anatomical features of valves. Review that if you need to. So let's talk about a mitral stenosis first and foremost. This is a pretty rare pathology. It's usually due to rheumatic heart disease. And because it's a stenosis, it means that we're having trouble putting blood into the left ventricle from the left atrium. And so if we look at the left ventricular pressure volume loop, what we see is that preload is down. Preload's down because it's not filling with as much volume. And that means that end-diastolic volume is down too, which is why the right side of this is going to be pulled to the left, right? So because the entire pressure volume loop is moved to the left, that means that preload's down. But everything else is fairly normal, because once blood gets into the left ventricle, well, it's home free. There's nothing disturbing its ability to get out of the left ventricle successfully during systole. So that's the PV loop. What kind of murmur do you hear with a mitral stenosis? Well, you're going to hear a heart sound whenever blood's hitting the valve. So when is blood hitting the mitral valve? Well, it opens up at the end of systole, right? And then it closes at the beginning of the next systole. So it's open all throughout diastole, which is why you hear the sound of a mitral stenosis murmur all throughout diastole. And it's going to be strongest right at the start of diastole, because that's when the valve opens. And so all the blood sitting in the left atrium is just going to all at once. And then it gets quieter and quieter, but then it spikes up again whenever the atrium contracts. And so that's going to, right at the end here, increase flow over the valve. And so the flow over the valve is proportionate to the sound that you hear. So because it's got a kind of a bimodal peak here, you can infer that the flow of blood over the mitral valve is the strongest, number one, at the start of diastole during kind of passive isovolumetric relaxation. And then number two, whenever the atrium squeezes. So what this leads to is a left atrium hypertrophy. And remember, we've said that a left atrium hypertrophy gives you AFib. not gives you AFib. Well, it gives you clots, and AFib can make that worse, right? Can give you endocarditis because of stasis. Can also create trouble swallowing and speaking, and that's because your left atrium is your posterior most chamber of the heart. And so when it hypertrophies and swells, it can press up against the esophagus, and it can also press up against the left recurrent laryngeal nerve, which is going to go to your vocal cords. And by virtue of the hypertrophy, it can compress these things and lead to deficiencies swallowing and talking. And then, of course, volume overloaded left atria. That volume can back up into the lungs, and it can give you dyspnea, orthopnea, trouble breathing, shortness of breath, pulmonary edema due to the high hydrostatic pressure, hemoptysis, that's blood in the cough. And then if it backs up enough, it'll back up the right side of the heart too, all downstream from this left atrial hypertrophy. Big takeaways is that it's a full-length murmur. It's a diastolic murmur. It's going to be loudest at the start and end of diastole. And you've got a loud P2 as well. And the loud P2 is due to the volume back up in the lungs as a result from the atrial hypertrophy. So let's get into mitral regurgitation or mitral insufficiency, which means that there's a hole in the mitral valve. Well, if there's a hole in the mitral valve, when is blood going to be going through the mitral valve audibly? And the reason it's pansystolic is because blood's leaking back into the left atrium when it shouldn't be during systole, because the mitral valve should be closed at this time. You hear the murmur because there's a hole in it. So on a pressure volume loop of the left ventricle, your preload goes up because it's pumping a little bit of blood back into the left atrium every time, so it can't get that blood out of the system. And your end diastolic volume goes up because, well, that's even more blood for your atrium to fill the ventricle with. But then your afterload goes down, and your afterload goes down because your cardiac output's going down, because some of the blood that you're supposed to be pumping out into the aorta, you're actually pumping back into the atrium. So that's going to lead to the characteristic PV loop of a mitral regurgitation. It's going to be wide and flat. And it's wide because the preload is up, the ventricle's volume overloaded. And it's flat because the afterload is down, because less blood is getting out to the aorta. You ought to remember that a mitral regurgitation or mitral prolapse / mitral insufficiency is due to this thing called myxomatous degeneration, which has many different causes, one of which is Marfan syndrome. Whenever you have a mitral valve problem, you're going to have left atrial hypertrophy in reaction. That's going to be one of the first changes you see in the heart. So again, that can lead to trouble swallowing, trouble speaking, and left atrial hypertrophy is also going to be associated with volume overload, so stasis of blood, so the encouragement of thrombi, and then those thrombi can embolize, especially if the patient has AFib, and AFib can be engendered by the stretching of conduction pathways brought on by the hypertrophy of the left atrium. So all these things play really closely together. Left atrial hypertrophy, that's the fundamental concept. And you can get a systolic dysfunction of the left ventricle, thinking all the way back. That's going to be your eccentric hypertrophy away from the center. And the reason why it's hypertrophying away from the center is so that it can accommodate this volume overload, because it can't get rid of this volume because there's a hole in the mitral valve. So again, pansystolic murmur, hollow systolic murmur, those mean the same things. The reason it's hollow systolic is because you hear it for the entire duration of systole because there's a hole in the mitral valve. Aortic stenosis now. This is a crescendo-decrescendo murmur. And the PV loop has a characteristically high afterload with a greatly diminished stroke volume too. This is the most common valve problem, remember, because it can be secondary to aging, and it's also hastened by the presence of a congenital bicuspid aortic valve. So because you can get it passively as you age, because it's so common. So thinking about the murmur, whenever your left ventricle contracts and it pushes blood out this stenotic aortic valve, well, it's going to push blood really rapidly at first due to the contraction, but then as the contraction slows down and stops, then the flow of blood from the ventricle to the aorta is going to decrease. And so when that decreases, what you hear on a heart sound is also going to diminish. Thinking about the pressure volume loop here, the high afterload is proportionate to the degree of aortic stenosis. And thus, the drop in stroke volume is also going to be proportionate to the degree of aortic stenosis. And the reason why stroke volume is going to go down is because when the pressure in the aorta is greater, well, that valve closes. Remember, the aortic valve opens whenever the left ventricular pressure becomes greater than the aortic pressure. And then when that goes up and falls back down, whenever left ventricular pressure is lower than aortic pressure, the valve closes. So the higher aortic pressure, the sooner that valve closes. That's going to account for why these patients have a weak pulse, because they're going to have a diminished stroke volume and a diminished cardiac output. And you ought to really know these symptoms and be able to tie them in your brain to aortic stenosis specifically. The mitral valve stuff, the big point of that is going to be atrial hypertrophy, and the symptoms are downstream from that. But then for aortic stenosis, the kind of hub idea is this diminished stroke volume that comes from the high afterload. And when you get this lower stroke volume, you're going to get a lower cardiac output, leading to chest pain because you're not perfusing the heart and meeting its oxygen demands. And you're going to get dizziness because you're not perfusing the brain and meeting its oxygen demands, right? And then you're also going to get this dyspnea on exertion because the left ventricle is going to be volume overloaded because it can't move all of its volume out at one time. So this is going to back up into the lungs. Again, know where your murmur is found, know which heart sounds or which locations correspond to each valves. And then here also, you hear a single second sound with an aortic stenosis. So a single S2, because A2 is soft. And the reason it's soft is a function of the decreased stroke volume, which is itself a function of the high aortic pressure, which comes from the stenosis of the valve. Finally, we've got aortic insufficiency, and this murmur is a diastolic decrescendo. And so we're thinking about the murmur. We hear, okay, it's a diastolic decrescendo auscultated at the right second intercostal space. And we're thinking, well, that corresponds to the aortic valve, right? And so should your aortic valve be heard? You know, should blood be flowing across the valve? Because that's what the sound is, blood flowing across the valve. Should blood be flowing across the valve in diastole? And the answer to that's no, because we know that the aortic valve should be closed during diastole. So if there's blood flowing across the aortic valve in diastole, we can inference that there's a hole in that valve somehow, or it's a leaky valve somehow. And that's what aortic insufficiency is. And so because there's a leak in this aortic valve, your left ventricle is going to be volume overloaded, which means that on a PV loop, the preload, or the right side of the square, is going to be dragged way out to the right. And it's also going to see a high stroke volume, and the high stroke volume obviously comes from the volume overload. But what you also see is a very high pulse pressure. And a pulse pressure is the width between systolic and diastolic, right? And so the fact that this gets taller tells you that pulse pressure is increasing. And this strong pulse pressure leads to strong peripheral pulses, and that's another characteristic diagnostic marker physically of aortic insufficiency and aortic stenosis, is that with this aortic stenosis, you feel weak pulses, and aortic insufficiency, strong pulses. So that's something that hopefully will set into your head over time. Don't be in a rush to memorize that. Aortic regurgitation is the least common valve problem. It's usually due to some sort of infection, can be syphilis, can be an endocarditis that spreads upwards to the valve. We know syphilis is going to create that tree barking aortitis because, well, it's a spirochete and it infects endothelial cells. And when it gets in your aorta, it just has a field day and they all turn necrotic. And the endocarditis spreads downwards into your valve. And then you can get an aortic insufficiency really acutely and emergently in the setting of a dissection. And that's going to be I think it's a type A DeBakey. It's the one involving the ascending aorta. Infective endocarditis, that can come from an IV drug abuser. And finally, wrapping things up, all these murmurs are going to get louder whenever the patient squats. Because we know that squatting increases preload. And if you increase preload, you increase the amount of blood hitting any given valve. And so you're going to increase the sound of the murmur. Right-sided murmurs are going to get louder on inhalation because you're increasing preload to the right side of the heart, right? But then left-sided murmurs are going to get louder on exhalation because whenever you exhale, your lungs go down, 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 down in size. So they become higher pressure systems. So they push blood into the left atrium. And that's all I got. Thank you very much for listening. I appreciate your time. Know the sounds, know the murmurs, know the locations, and know the consequences.